Hello, everyone. Thank you so much for joining this presentation. Ariel and I are delighted to talk to you about unlocking the EMR's potential, pharmacist-led strategies to increase patient safety. Ariel and I have no relevant financial relationships to disclose related to this presentation today. After completion of this presentation, we're hoping that pharmacists and pharmacy technician learners will be able to summarize EMR tools and standard priorities of use within their daily inpatient workflow, to describe patient cases where pharmacists were made aware of potential medication safety events through an EMR role-based tool dashboard, and lastly, to identify more medication safety prevention opportunities pharmacists have through EMR data. I wanted to start with some background on SSM as an organization. SSM is a large Midwestern healthcare system located in Wisconsin, Illinois, Missouri, and Oklahoma. Our corporate headquarters is in St. Louis. The pharmacy enterprise is involved in care delivery across our 23 hospitals, in our medical group offices, and we also have numerous community pharmacies. We have strong relationships with our affiliated organizations, Dean Health Plan and Navitus. Ariel and I have spent the majority of our career practicing and leading in the inpatient space, which now involves leading pharmacy practice across our hospital settings. When Ariel and I started our work on the pharmacy practice model, we discovered that we had 23 hospitals with pharmacists practicing very differently. As we embarked on our standardization journey, we felt it was important to have a vision that would guide us as we tracked toward a more unified practice model. We felt it was incredibly important to harness technology to make pharmacists more efficient, which ultimately would keep our patients safer. Thus, we came up with our vision statement, which is to optimize patient safety and medication management through innovative technology, empowering pharmacists to deliver exceptional care and maximize healthcare value to our patients. Within pharmacy, over the last 2 years, we have been intentionally working to make the pharmacy enterprise an HRO. For those of you who are unfamiliar, an HRO organization is one that operates in a complex, hazardous environment without serious accident or failures. Aviation and nuclear industries are common types of HROs that often healthcare tries to use as examples. At SSM, we feel an incredible dedication to keeping our patients safe, and we believed that leaning into HRO principles would help us create a foundation for our practice model that would maximize patient safety. I wanted to give some examples of each of the HRO principles because as we continue in this presentation, we will directly tie our work to these principles. The first is a preoccupation with failure. So thoughtfully designing workflows and systems to think about what-if situations and always considering any changes in the context of how does this impact safety helps design systems with better error proofing. A reluctance to simplify. Life is so much easier if a situation is all or nothing, but as we know in healthcare, that is rarely ever true. Truly understanding the complexity of a situation and trying to design to accommodate for that complexity helps us ultimately create better solutions for our patients. A sensitivity to operations. Pharmacy is complex. We have numerous workflows involving the intersection of human beings and multiple types of automation and technology that we use on a daily basis. Truly understanding how and where work gets done and having strong feedback loops from the front line to leadership allows teams to pivot quickly when a safety concern is escalated. Commitment to resilience. So we need to build systems that are adaptable when challenges arrive. We saw with COVID, our supply chain wasn't resilient. We had many drugs sourced only from one country, and we learned some hard lessons from COVID. As we continue to learn from these failures and adapt for the future, that will make us more resilient. And then deference to expertise. The front line is doing the work day in and day out. They absolutely need to be involved in a shared decision-making model when you're trying to make changes that impact them. And in fact, it's really important to include all of the disciplines that could be impacted to gather their perspectives, because ultimately that will lead to better decision-making. As we thought about standardizing the practice model, we looked at the pharmacist activities through the lens of how that activity keeps patients safe. I think sometimes we lose sight in the midst of our daily tasks of the true purpose of our tasks and why we feel it's important to dedicate the time and energy to these specific responsibilities. So, when we zoom out and we think about the different activities of the pharmacist, we can look at the process of admission histories. And really, what we're doing from a safety perspective is we're ensuring accurate medication lists upon admission to the hospital, because the downstream impacts, as we all know, of an inaccurate medication list is that it's going to lead to medication errors. Order verification. This is really the very foundation of what inpatient pharmacists do. They're verifying the appropriateness of new medication orders based on current patient clinical condition. For our dosing protocols and consults, we're managing dosing and monitoring of complex medications because we know that having accountability for that and being able to monitor that closely leads to safer outcomes for our patients than when providers are managing it. And then medication monitoring. This is where we review our medications and labs and that the patient is on an ongoing basis throughout the patient's stay. For medication reconciliation, we are confirming that medication orders are correct upon admission and discharge. For multidisciplinary rounds, we will confer with the team related to the patient's clinical scenario and make recommendations. This is really our opportunity where we're holistically hearing what's going on with the patient, and we can make recommendations that are really going to optimize outcomes for those patients. And lastly, patient education. This is very important for patients to really understand their medications, especially when they are embarking on a big change as they're discharged from the hospital to their medication regimen. And so it's a great opportunity to really provide that education, which ultimately will keep the patient safer. As we were deciding to use Epic in a uniform way and create standard work, we chose to focus on medication monitoring because we recognize that we have the most opportunity in this particular area to improve our processes and positively impact patient care. During a baseline assessment where we surveyed all the hospitals, we determined that almost all of our hospitals were monitoring patients differently. They were using different Epic functionality to monitor patients, and they prioritized patients differently. We did not have a standard of care, and this variation was leading to quality and safety gaps. As a team, we leaned into several HRO principles by harnessing and optimizing technology in a standard way to drive better outcomes. For us, this meant using an Epic EMR dashboard to create rules, which were decided by a team of frontline clinical pharmacists, and a prioritization methodology to ensure the highest risk patients were addressed first. As opposed to monitoring a patient once in the morning and then having a lab or clinical condition go unnoticed later in the day, this new framework was more sensitive to these types of changes and alerted the pharmacist. So we really leaned into the principle of sensitivity to operations for our HRO journey. And we wanted to use real-time data visualization, and the application of that was prioritize monitoring rules that pushed only when the clinical conditions were met, so that the pharmacist could then review and make an assessment of that patient in that situation. We really felt that it was extremely important to have expert input, which is why we convened a group of frontline staff to determine what rules that they felt were the most clinical relevant and have them determine the priority. And then also creating a shared mental model. So we knew we needed to develop standard work to assess and address the rules. Otherwise, we would continue to have variation because pharmacists would receive the rules and then they would assess all their patients differently and they would follow up in different ways. So one of the decision points that we needed to look at was why did we want to use a monitoring dashboard and drive rules to the pharmacist dashboard as opposed to adding to our current repertoire of best practice alerts? Because best practice alerts are often used to notify pharmacists of a specific situation so that they can then address the situation. But best practice alerts have real disadvantages. The literature suggests that they only minorly improve targeted processes of care, regardless of the discipline that's receiving the alert. Clinicians override the majority of alerts, even critical alerts. If you are currently practicing, I'm sure you have been barraged by best practice alerts before and have dismissed them. BPAs ultimately can be very disruptive to the workflow, and they are often not thoroughly assessed for this reason because the clinician in that moment is very focused on their task completion, and it breaks their flow when the BPA alerts them and they have to cognitively switch gears, which they end up then dismissing them, and then they want to go back and figure out, oh, what did that BPA say? And then they can't find it. And I found this to be really interesting when we look at aviation as an HRO model. So, cockpit technology is rigorously designed to provide only highly consequential alerts to allow pilots to maintain situation awareness. So, I feel like in healthcare, we have designed it to be the opposite, where everything dings and rings and alerts clinicians. And so we become very desensitized to these type of alerts. And then lastly, rules are prioritized and are specifically designed to fit within the pharmacist's daily workflow. So once they are in the cognitive headspace of I'm going to be doing my monitoring, they then have a framework to follow and they have the flexibility and at that point in time to then do their monitoring. Creating standard work on the assessment allows us to onboard our new pharmacists and residents, ensure they have a strong starting point on how to assess clinical scenarios in their patients. We use this as an opportunity to defer to the expertise of our pharmacy specialists, such as transplant and critical care pharmacists. For example, our transplant team worked through tacrolimus rules, critical care specialists provided guidance on our CRRT rules, which the feedback from our general unit pharmacists were they were really appreciative that they had that expertise embedded in the standard work. Additionally, we had our antimicrobial stewardship pharmacy team build out all of our antimicrobial rules. We have heard feedback from our preceptors that they use the standard work as a starting point with residents and students to guide their training. Residents have stated that they feel more comfortable and assured on their first solo staffing shifts because if they encounter an unusual clinical scenario, they often have the standard work to refer to on what they should be clinically assessing.
Let's move into the dashboard. Let's start with two patient cases. Patient case number 1. This patient was admitted for observation after complications associated with an ablation. They are now considered stable and discharge orders were placed. While preparing the patient to go home, the AM labs returned with an elevated serum creatinine level increased from 1.3 to 2.3. Now, let's be honest. How many of us know that we have busy morning processes when trying to discharge a patient, get them out the door? We're trying to meet those metrics of get them out by noon. And we're all functioning within this trusted assumption that they are stable and ready for discharge. Prior to our dashboard being in place, which we refer to as Project Cosmos, our healthcare teams are regularly focused on getting the patient out the door. In this scenario, the patient would have potentially been discharged home heading into an AKI, resulting in a readmission. Luckily, this was after Project Cosmos was in place, and our pharmacist was notified using the electronic medical record clinical monitoring dashboard with our rule, intervene, serum creatinine increased 50% or more in the last 7 days. The pharmacist was able to review and see what was going on, notified the care team, and was able to delay their discharge and treat the patient for their AKI. For our second patient case, we had a patient that was transferred in from an outside hospital where their original blood work was completed. The patient was being treated for an infectious disease while admitted, and on the morning of discharge, that outside blood culture grew E. coli. Prior to Project Cosmos, patient would have likely discharged without an antibiotic therapy and would have likely resulted in a readmission, possibly even septic. With our dashboard in place, our pharmacist was notified using the EMR dashboard that they needed to intervene, positive blood culture, and no antibiotic therapy. The pharmacist was able to review the rule that was pushed, notify the care team, and delay the discharge in this scenario as well. And the patient was able to receive the appropriate antibiotic therapy. What was the problem we saw prior to harnessing the benefit of technology? As you saw in the cases, what are the odds someone finds or is even looking for the changes that occurred in those patients? We truly hope high, but we didn't actually know how many things we were going unseen or missed because unless we thought to dig for them, we didn't know there was a change. In another way, How many of you have walked into your day, think you prioritized your most complicated patients at the beginning of the day, just to find out the most complicated patient was the one no one was talking about at the end of your shift as your brain is getting ready to turn off? By unlocking search functionality within the electronic medical record, we were able to set up rules with predetermined criteria that the EMR can be searching for at all times. And as soon as the predetermined criteria is met on a patient, the pharmacist gets a notification pushed to them real time to their monitoring dashboard or patient list. The pharmacist can then enter the patient chart to take a deeper dive into what is going on. Awesome. We have more alerts pushing. Not necessarily the case. We have turned these into purposeful alerts. So, to prevent alert fatigue as much as possible, we needed to define when the pharmacist needs to consider a notification as high priority and when they consider it moderate to low priority, and work to review within their shift. By standardizing the definitions around the dashboard columns, the build teams are able to place new rules into the correct locations based on priority of review, which supports the frontline pharmacists to have clear expectations around which patients they should start with at the beginning of their day and then reprioritize throughout their day as those rules push. As you see here, intervenes are considered stat now, which include our med safety and time sensitive rules. The pharmacist would move into reviewing patients with consults as the next priority. As we know, this is med management or delegated med management therapy to the pharmacist. The pharmacist is expected to work up the whole patient when reviewing consults, so then would prioritize, assess, and monitor rules along with the consult that they're doing. As they finish up all their patients with consults, they would move into the next priority, which would be our assess, which is completing or reviewing within the shift, and monitor, which is review within the patient's stay. Continuing with the mindset to decrease the cognitive load and setting clear expectations for our pharmacists, we developed standard work for each individual rule. Moving from left to right, you have the rule display name, the minimum clinical assessment associated with that rule, the rule sign-off reason and when to use them. For example, for the reason sign-offs, if you contacted a provider to make a recommendation that was supported by that rule, you would select contact a provider when signing off on the rule in the dashboard. And last in the row includes the criteria that needs to be met for the rule to push to the dashboard. Now we're going to discuss how you would actually defer a rule. Per our previous clinical dashboard overview, you saw that for each column that has rules pushing to it, when you enter the patient chart, the rule is listed under those column headers. When you enter into the patient chart and go to your clinical dashboard, you will see the rule listed here as you do at the top of the screen. So in the example here, intervention needed, this would be your intervene, stat now, or time sensitive rule that would need to be looked at right away. So intervene, daptomycin, and no CPK. The rule will pop up there. And maybe you're asking yourself, I've never seen this rule. I have no idea what to do with it. At that point, you would go to what we just discussed at the RX clinical scoring under your web links page. You would click on that RX clinical scoring link, and then you would be able to go into the internet page and find the standard work for your intervene rules. When you enter into the intervene rule standard work, you're able to click quickly or Control F to go to intervene, daptomycin, and no CPK. Once you're in the standard work, you can see that it supports the clinical assessment to evaluate the indication for daptomycin and make recommendations to order the CK baseline level with repeat in 7 days if you're going to continue care. The next 4 sections of the standard work support how you would sign off on the rule. So it gives you a deferral time frame, and then it gives you comments to sign off on that rule. And last but absolutely not least is the criteria for pushing. If you're wondering why the rule pushed to you, you will be able to locate that information there. So this rule returns a value of 1 if the patient has an active order for daptomycin, but no CPK or CK result within the last 7 days. All right, so now you know why the rule pushed to your patient and how to address it based on the standard work listed within the rule table. So you'll go back to the rule, complete the clinical assessment, making sure the patient is appropriately on daptomycin with an appropriate indication. At this point, you would reach out to the provider and recommend ordering a CPK level. When you come back to sign off on your rule, you would click Other. You're going to defer current encounter if the CPK order recommendation was accepted and they're placing it, or you can divert for up to 2 hours, making sure that the physician puts in the order. For your reason to defer, you're going to select Contacted Provider, and in the comment box, state recommended ordering CPK. Once you have entered all of those fields, you will click Accept and sign off on your rule. Once you have clicked Accept and signed off on your rule, your dashboard then will clear it out, and you will be able to scroll to the bottom of your clinical dashboard to see that it is signed off there. Every time you click Accept on this rule, it drops a metric for us to be able to record and support in stating the clinical performance you did for this patient. All right, it's demo time. So let's go into our electronic medical record and show you what this looks like. Pulling it all together, what does a day in the life of a pharmacist with the scoring deferral dashboard look like? Per our general standard work, the pharmacist would come in and have high priorities and moderate priorities for the day in terms of managing their patients. For high priorities, we include order verification and emergency responses. If those are the responsibilities within your shift, those are high priority and need to be regularly looked at and managed for your shift. Then we would move our high priority into the dashboard to support prioritizing our patients who need the highest need of med management therapy for the day. Those high priorities are considered our intervenes and our consults. So we start with our intervenes as our highest priority in terms of our columns, as those are considered our stat now, patient safety, or time-sensitive rules. The pharmacist would come into their patient list. They would click on their intervene column and pull the patient with the highest numerical value to the top of the list. What that allows the pharmacist to do then is to add another layer of prioritization by hovering to discover to see what rules and safety measures are pushing on these patients. At this point, the pharmacist would be expected to go into the patient, see what's going on with that safety scenario or time-sensitive scenario, review the med management around it, and start working up the collaborative discussion they would have with the provider and nursing team. At this point, they wouldn't be concerned with all of the other rules, as these rules are pushing for a specific reason in terms of that, again, that patient safety and that time-sensitive need. Once they've made the recommendation or worked with the provider, followed up on what's going on with the patient, recognize that there's already action being taken, they would sign off on that rule and come back into their patient list and start working on the next patient that has an intervene rule pushing on them. Once all of the intervene rules have been addressed for their patients, the next high priority would be the consults. So consults are med management that has been delegated to our pharmacy team. And so that is high priority because we are solely responsible for taking care of that patient's med management. In this scenario, the difference from looking at the intervene rules versus looking at the consult rules is we're going to work up the whole patient to manage our consults. If I'm doing a warfarin or a Venco, I'm not just looking at the warfarin and Venco. I have to look to see what's going on with the whole picture of the patient to best manage their care. And so with that, we're using the assess and monitor rules on those patients as well to help us recognize what medication management therapy needs to be prioritized when we're in that patient's chart. So when I'm looking at a patient who has a consult rule pushing on them, I'm looking at all of the rules, not just the consult, but I'm using the consult to prioritize them to the top of my list. Once you've completed your consults and your holistic review of your patient, then you'll move into your assess and monitor columns. Those are considered more moderate priority for the day. Assess are going to be rules that we aim for the pharmacist to review within their day, so within their shift. Monitor are going to be rules we aim for them to review within the patient's stay. So for example, if I hover to discover on some of our monitors, you're looking at your high-risk meds that do not necessarily need daily monitoring, but we want the pharmacist to be aware that a patient is currently on those therapies, and they should be watching closely throughout their stay. All right. So now we're going to go into a patient and look at how that looks when I actually do a holistic review on Ginger. So I come into Ginger and I immediately have my clinical scoring dashboard pulled up. The goal of the dashboard was to have all information the pharmacist would need to review the med management within 2 clicks. Another feature that's beneficial of this dashboard is the rules can also live in your sidebar, which allows the pharmacist to move within the chart for the information that they need to support the med management that pulled them into the chart from the rules. So with Ginger, I come in and I see I have a warfarin per pharmacy and a prior to admission meds history not reviewed. Awesome. Maybe this is the first time you've come in and you're not exactly sure what to do with those rules. So right up here in the web links, we have one single link to our RX clinical scoring standard work. I can click that and it's going to open right up to that standard work that we were talking about in those standard work tables. So in this scenario, I would be able to click consult rules. I would be able to go and search for my consult warfarin per pharmacy. When I click on that, it's going to jump me right to the table with my minimal clinical assessment, how I would sign off on the reason buttons within the rule, and it's also going to let me know what criteria is pushing that rule to my dashboard. So now that I've looked at my rule and I understand what's expected of me, I pull up my system guideline around my warfarin dosing and I start working up Ginger. Let's say I've done my workup. It's been about 5 minutes. I know what she's here for. She's got atrial fibrillation. She's been on warfarin. This isn't new for her. I'm able to get a dose figured out and ordered for Ginger. I've worked up her prior to admission meds with the technician, and she's looking good. We're sitting pretty with Ginger. So I've done my holistic review around her care for today. So at this point, I'm going to go in and sign off on my rules before I complete any of my general documentation around my consult. So I'll go into my dashboard. I'll select Other. And you can see that the rule is right here. So consult warfarin per pharmacy. There's a lot of options in how you sign off on it. And we do support that within the standard work with a range of how many hours you should be deferring the rule for. That allows the pharmacist to have some clinical autonomy in terms of when they want it to repush. So Ginger's sitting pretty good. I don't really need any further follow-up today or a reminder to look into her later today. So I'm going to select the date and have the rule repush tomorrow as long as the criteria still applies. In this scenario, the criteria is a warfarin per pharmacy. So the only way that it would no longer apply and push at 7 o'clock tomorrow is if the consult was discontinued. We also have these deferral buttons here that you could easily select defer for 12 hours. Since our general workflow does not have our second or third shift living in the dashboard, many of our pharmacists will select defer for 12 hours and just have the rule push later in the evening. I looked through Ginger. It took me about 5 minutes. As I stated, she had been on warfarin before, so it was a pretty easy consult to review. So I'm going to select 5 minutes as the time that was spent. And because I was working within the scope of my practice under a warfarin per pharmacy guideline, I'm going to select scope of practice. If there are any comments that I wanted to leave around Ginger's care and have it connected to the data supporting the consult warfarin per pharmacy, I would be able to leave that information here and it would report out along with this rule. Every piece of information you see within this advanced view is reportable data. So the rule title, the defer time, when I sign off on this, how much time I spent, what was my reasoning for signing off on the rule, and any of those comments are all reportable into an Excel. At this point, I would click Accept. And now you can see here that the rule has signed off. I can still visibly see what rule has been deferred. I can even hover to discover to see how many times this rule has been signed off and by whom. While the rule is being deferred, think of it like a break. There's a break holding the rule down. It's suppressing it until 7 tomorrow morning. I can see that it's down below, waiting to repush. As long as the criteria still applies, at 7 o'clock tomorrow morning, this rule will repush to my dashboard and refresh up into my consult bucket to be re-reviewed. In the scenario that the criteria no longer applies, the rule will clear itself. I'll say that again. In the scenario that the criteria no longer applies, the rule will clear itself. For example, let's say the technician completed the prior to admission med history and I was not able to sign off on the rule before the med history was stated as complete. This rule's criteria is looking for a prior to admission med history that has not been reviewed. As soon as the information has been selected that it has been reviewed, the criteria for the rule no longer applies, and this rule would clear itself. That's important because there are many times that rules will push, let's say for a blood glucose level, or for a lab that came back, or for an order that can be discontinued with a de-escalation or maybe an IV to PO. And many of times, our physicians are also taking care of those orders and supporting the med management. And those rules will clear as soon as it has been addressed and adjusted because the criteria no longer applies. So it supports a team effort that the rules will only push when the criteria applies. That also means because the criteria can apply at any point during a patient's stay, that these rules are real time. So let's say I was working up Ginger and labs came back on some of my other patients. As soon as I come back out into my patient list, there may be new intervenes that have pushed that I need to review. There may be new consults that have pushed since I have been in Ginger's chart. Because the rules are real time, the patient list is always updating. So throughout my day, I would want to come in and resort my intervenes and hover to discover and resort my consults and hover to discover to make sure that I'm still prioritizing my high priority patients. One of the key features that drew us to using the electronic medical record dashboard was the ability for us to have metrics around all of the rules that we had pushing to the pharmacist. By using the EMR to help the pharmacist prioritize patients and embedding the review process into their standard workflows, we are able to see over 68,000 data points each month across our system of 21 hospitals. Of those, we consistently have about 6,000 to 9,000 touch points related to medication safety or time-sensitive reviews from our intervene bucket. Some of the most common are a drop in blood glucose, high-risk insulin therapy, abnormal drug levels with active drug orders, and renal function changes. But we are also harnessing the potential of using the tool for more proactive med management, as you can see here, and based on the prioritization statements earlier. We learned early on in the rollout process that we really wanted to engage our frontline staff. We wanted to engage those who were actually using the tool to optimize it and grow it to its full potential. Our foundational team, now known as System Council, advocated for these frontline pharmacist councils to really act as a middle group to represent the team utilizing the tool, be closest to the clinical activities, and be a voting member for the different hospitals. Those representatives were selected from each region by an application process. They represent and support their home-based based hospital plus one other ministry within their region. They are the voting members around any of the clinical optimization or changes that occur within this tool. One of their main responsibilities as a council member is to do catchball or obtain feedback from our frontline teams. Team members can use two different ways to submit feedback. We have an online forms link or a QR code that they can scan with their phones. All council members have access to the feedback provided through the QR codes and are responsible for reviewing, obtaining more details, and presenting that information to the larger group for discussion. When we send out recommendations and start the catchball, it's about a 2 to 4 week process that we give the rest of the frontline team members to review and provide feedback. As a council member, they will bring all of their feedback to a roundtable discussion at a set meeting in which we will prioritize voting on making those changes. Let's talk about voting. Each member represents two of those ministries. They are considered the voting member for that ministry. And so it is very important that they continue to build rapport with their home base hospital and their supported hospital, as they are the voice for that team when voting. And then, as many of you would assume, that goes back up to our system council team. So our frontline council really work as the catchball middle team to work with their colleagues, their frontline colleagues, and prepare and vote on any optimization or change around this tool, along with the standard work that supports the tool. And then once something has been voted for approval, it gets sent back to the system council for further discussion on how to prioritize and roll out that approved change.
I would like to now share some final thoughts as we transition into the optimization phase of this project and to tell you where we would like to continue to grow our practice model and the use of our dashboard and standard work. The overwhelming feedback from frontline pharmacists is that they enjoy having a standard dashboard in Epic that allows them to prioritize their work based on highest acuity clinical situations and patients. It has certainly been a mind shift change for some pharmacists to not monitor all their patients and trust in the system to alert them when there is a clinical situation that warrants their attention. However, with time, the trust is being built, and the pharmacists are seeing the value in this type of model. This is especially true on weekends and evenings when staffing runs leaner and it's very challenging to monitor all patients. Additionally, preceptors appreciate having standard work and a monitoring dashboard to utilize with students and residents. For example, they initially give them renal and IV PO rules for students to work on, and then expand the clinical difficulty as the learner grows. We have additionally had positive feedback from our physician partners. When the hospitalists were attempting to focus on heart failure readmissions, we were quickly able to drive a rule to our dashboard for high-risk patients, and the councils adopted and created standard work to facilitate taking care of this particular patient population. We can continue to replicate these types of initiatives using our rules framework. Lastly, I spoke some on the minimal effectiveness of BPAs. Due to thoughtful building out of the rules, we were able to eliminate numerous BPAs that often fired during verification, which upon investigation, we discovered wasn't usually the right time to alert the pharmacist and was disruptive to their workflow. So we had over 2,500 less disruptive alerts per month as a result of this project. In summary, this monitoring dashboard and standard work has provided many benefits to us. There has been strong feedback regarding our general adult population and the dashboard rules in terms of its benefits. So much so that we are hoping in the next year to create specific rules for pediatric and critical care populations. Our ambulatory pharmacy colleagues are also working on their own standard dashboard to prioritize their patients. We have partnered with our internal data scientists to parse out the free text in our intervention data to synthesize some of the clinically meaningful changes the pharmacist has initiated. As Ariel had mentioned, at this point, we're amassing so much data, and so we're really excited to be able to build a large language model so that hopefully we can really pull out and glean meaning from all of this free text. Lastly, we intend to continue to closely align with provider initiatives to continue to expand our pharmacy practice model and influence. Some final key points for us to part with. The EMR has the potential to allow the pharmacist to work more efficiently and decrease the cognitive load of searching within the chart for relevant updates. Our whole goal with this project was to make pharmacists more efficient and to push the scenarios to the patient or to the pharmacist as opposed to them having to search for them. Standard work around how to use EMR tools provides clear expectations for the pharmacist. This is especially beneficial for new pharmacists and residents as they onboard. And data. By embedding the EMR tool into the daily workflow instead of expecting the pharmacist to document a separate intervention, we have amassed a large volume of data that truly captures all that the pharmacists do around patient monitoring. However, we are still processing how to analyze and harness the data, and we'll be excited to come back and share those results with you in the future.
Learning Assessment 1. True or false? Rules push real time, meaning as soon as the criteria is met, the rule pushes to the pharmacist patient list to notify them changes need to be reviewed. This is true. Number 2. Select the correct order of prioritization used by the speaker's organization when reviewing the patient dashboard. The correct answer is C. Intervene, consult, assess, monitor. Number 3. Which of the below is a potential patient safety rule that could be considered by organizations for inclusion in their electronic health record? D. All of the above.